figuring out what truly works in medicine, it can sometimes feel like a bit of a journey, through murky waters. Treatments gain popularity, then maybe the evidence shifts, and we're left wondering, well, what was really effective?
Absolutely. It happens.
And today, we're taking a deep dive into a really compelling example of this. Carotid Endarterectomy, or CEA. Its early use saw quite a bit of enthusiasm, I gather, but the firm proof of its benefit, that took a while to really solidify.
Exactly. The basic idea behind CEA, surgically clearing out a blocked carotid artery to prevent a stroke, it just made intuitive sense. So it got adopted pretty rapidly. But like you said, the really robust evidence, the kind you need to be sure, that wasn't there right at the start. And that led to questions, even a decrease in its use by the mid-1980s.
Right, and that brings us straight to the heart of our discussion today. We're tackling a really crucial question. For people who've recently had some kind of cerebrovascular event, like a TIA, a mini stroke, or maybe a minor stroke, and they have significant narrowing of a carotid artery, does surgically clearing that artery actually lower their risk of having another stroke down the line?
Yeah, that's the core question. And our sources today offer some pretty compelling answers, actually.
You really do.
Our main focus is going to be this groundbreaking 1991 article in the New England Journal of Medicine. It's titled Beneficial Effect of Carotid Endarterectomy in Symptomatic Patients with High-Grade Carotid Stenosis. It came from the NASET collaborators. This study, NASET, along with some other key research around the same time, it was a real turning point. It fundamentally changed how we understand who benefits most from CEA.
Okay. So for you listening, our mission today is to unpack the impact of this really pivotal research. We want to understand why it was so important in shaping stroke prevention, and frankly, why its findings are still so relevant all these years later. All right, let's get into the details. What was the situation like before this landmark NASET study? What was happening with CEA then?
Well, like we touched on, the landscape was pretty uncertain. CEA had that initial period of, enthusiastic use just based on the logic of it. But by the mid-'80s, the lack of solid proof, that led to some significant doubt creeping in. There was actually a 1984 article in the journal Stroke. I think the title was something like Carotid Endarterectomy, Does It Work? Really provocative.
Wow, yeah. The title really cuts to the chase.
It did. It captured the skepticism that was growing, especially among neurologists and internists.
So they were looking at this procedure with some serious reservations. What were their specific concerns? Why the doubt?
Well, there were a couple of big things. One major issue was just inconsistency. The way CEA was being used, the criteria for deciding who should get the surgery, it wasn't always clear or standardized across different places. Plus, there were increasing worries about the complication rates being reported, at least from some centers, things like stroke or even death related to the surgery itself.
Yeah.
So it wasn't seen universally as this reliably safe and effective treatment yet.
It sounds like there was a real, almost urgent need for some solid evidence, either to back up the procedure or to show it wasn't worth the risk. Who stepped up to address this uncertainty?
Interestingly, it was often the vascular surgeons themselves who kind of saw the writing on the wall. They recognized this need for clear, evidence-based support. They were seeing the decline in CEA procedures and understood that, look, if we believe in this, we need to prove it works with well-designed clinical trials.
Ah, okay.
And that proactive stance, that really led to the development of several crucial studies, including the NASET trial that we're focusing on.
Which brings us right to it. The centerpiece, the NASET study. Can you walk us through the key elements? What exactly did they set out to do?
Right. So NASET was a randomized controlled trial, the gold standard for figuring out if a medical treatment works. It was a big undertaking, involved 50 medical centers across the U.S. and Canada. And importantly, they looked at patients based on how narrow their carotid artery was, the stenosis. They had two main groups initially, sort of moderate, 30 to 69%, and high grade, 70 to 99%. For today, we're really zeroing in on the results from that high-grade stenosis group, the 70 to 99%.
Okay, high-grade stenosis. And who were these specific patients? What kind of recent health events put them in this category?
So these were people who had recently, and this is key, within 120 days experienced a neurological event. That could have been a hemispheric TIA, so affecting one side of the brain, or a retinal TIA affecting an eye, basically those temporary mini strokes. Or it could have been a non-disabling stroke. And crucially, they also had that significant narrowing, 70% to 99%, in the carotid artery on the ipsilateral side as where their symptoms occurred.
Got it. So the symptoms lined up with the blockage, and it was a pretty severe blockage. What was the actual experiment? What treatments were compared?
Okay, so everyone in the study got what was considered the best medical care available at the time. That definitely included antiplatelet therapy like aspirin to help prevent clots. Then they were randomly assigned, like flipping a coin, into one of two groups. One group just continued with that optimal medical therapy alone. The other group got the medical therapy plus the carotid endarterectomy surgery, the actual removal of the plaque buildup in the artery. And these surgeries were done by experienced surgeons, neurosurgeons, or vascular surgeons.
Right. And how did they track what happened to these patients? How did they measure the outcomes?
They followed them really closely, regular neurological exams, initially quite frequently, then every 4 months after the first year. And here's something really important for the quality of the study. The main outcome, whether a patient had a stroke, was assessed by independent reviewers who are blinded.
Meaning they didn't know which treatment group the patient was in.
Exactly. That helps prevent any bias, conscious or unconscious, from creeping into the results assessment. It makes the findings much more reliable. Oh, and another remarkable thing, they had zero loss to follow up. Every single patient was accounted for, which is pretty amazing for a trial this big and long.
That is impressive. Okay, so the moment of truth, what were the key findings? What did NASET actually reveal for that high-grade stenosis group?
This is where it gets really significant. The difference between the groups was, frankly, dramatic. Over 2 years, they looked at the cumulative risk of any stroke happening on the same side as the narrowed artery, the ipsilateral side. In the group that only got medical treatment, that risk was 26%.
Okay, it's 26%.
In the group that had the surgery plus medical treatment, that risk plummeted down to just 9%.
Wow, from 26% to 9%.
That's an absolute risk reduction of 17%, and statistically, it was highly significant. The p-value was less than 0.001, meaning the chance of this happening by random luck was incredibly small. To put it another way, you'd only need to perform CEA on about 6 patients like these to prevent 1 stroke over 2 years. That's a really powerful effect. Number needed to treat of 6.
Yeah, that's a very impactful number. But what about the really bad strokes, the major ones or the ones that were fatal? Did surgery help there too?
It did, and the results there were arguably even more compelling. For major or fatal ipsilateral strokes, the rate was 13.1% in the medical-only group, compared to just 2.5% in the surgical group.
Just 2.5%.
Right, so that's an absolute risk reduction of about 10.6%. Again, highly statistically significant.
So it wasn't just preventing any stroke, it was specifically preventing the most devastating kinds of strokes.
Precisely. And the benefit held up even when they looked at the bigger picture, all strokes on either side, plus all deaths. The surgical group still came out significantly ahead. The conclusion from the NASET investigators was pretty clear and direct. For patients with recent symptoms related to high-grade stenosis, CEA is highly beneficial. It offers substantial protection.
It really sounds like NASET provided some incredibly strong, almost definitive answers for that specific patient group.
It really did. It wasn't just suggesting a benefit, it was quantifying a very large one. It reshaped how doctors thought about managing this condition.
Okay, so the NASET results were obviously a very big deal. But, in science, one study is great, but replication or supporting evidence is key. Was this just a one-off finding, or did other research back this up?
That's a crucial point. And no, NASET wasn't alone. Its findings were strengthened by other major trials happening around the same time. For example, there was the VA Cooperative Study 309. It focused on men and also found a significant benefit for CEA. It looked at stroke or crescendo TIAs. Those are TIAs that get worse or more frequent. After 1 year, the rate was about 19.4% in the medical group versus only 7.7% in the CEA group. Again, a clear benefit.
Okay, so another study pointing the same way.
And then there was the European Carotid Surgery Trial, the ECST, another large, important study. While its methods for measuring stenosis were a bit different, its overall conclusions also supported the benefit of CEA in symptomatic patients with severe stenosis.
It's fascinating how these major independent efforts kind of converged on the same conclusion. That must have sent a pretty strong signal to the medical community.
Oh, absolutely. The signal was so strong, in fact, and the benefit in that high-grade symptomatic group was so clear and maybe even larger than anticipated that a clinical alert was actually rushed out and published in the journal Stroke. This happened even before the full detailed NASET results were formally published.
Really? An alert before the full paper?
Yeah, basically saying, hold on, the evidence for surgery in this group is looking incredibly strong. Doctors need to know this now. It highlighted just how impactful these findings were considered to be.
So these trials, NASET, VA, ECST, They really cemented the role of CEA. What's been the long-term impact? How did this change guidelines and actual practice?
Fundamentally, these trials provided that missing piece, the robust, high-quality evidence needed to confidently recommend CEA for the right patients. They established its place in stroke prevention. If you look at medical guidelines now, it's standard practice. There was a big international systematic review in 2015 looking at loads of published guidelines on managing carotid stenosis from around the world, and the consensus was overwhelming. 94% of the guidelines recommended CEA for symptomatic patients with stenosis, somewhere in the range of 50% to 99%.
94%. That's about as close to a universal agreement as you get in medicine, isn't it?
It really is. NASET and the others didn't just tweak a guideline. They became a cornerstone of how we try to prevent strokes in these individuals.
Okay, that's very clear. But medicine is rarely black and white. Are there nuances here, ongoing considerations we should know about when thinking about CEA? It's not just stenosis plus symptoms equals surgery.
Right. You're absolutely right. There are definitely important nuances. One big one is the timing of the surgery. There's growing evidence suggesting that the benefit of CEA might actually be greatest if it's performed relatively soon after the TIA or minor stroke happens.
So acting quickly matters.
It seems to. That initial period after a symptom might be a particularly high-risk window for a subsequent, potentially larger stroke. A retrospective review from the Mayo Clinic, for instance, looked at their experience and suggested that in carefully selected patients, doing the CEA within the first 2 weeks after a TIA could be done with acceptable risk.
Yeah, that makes sense. Intervene during that vulnerable period if possible. What about how well these guidelines are actually followed in the real world? Is everyone who meets the criteria getting the surgery appropriately?
That's another critical point, and the answer is maybe not perfectly. There was a Canadian study by Kennedy and colleagues that looked at the large number of CEA procedures performed across different regions. They found quite a bit of variability in how strictly the criteria for appropriate use were being followed.
Meaning some people might be getting it who shouldn't, or perhaps vice versa.
Exactly. They even identified a certain percentage of surgeries that, based on the established guidelines derived from trials like NASET, appeared to be inappropriate. Maybe the stenosis wasn't severe enough or the symptoms weren't clearly related. It really highlights that even when you have strong evidence like NASET, ensuring that evidence is applied correctly to the right individual patient, well, that remains a constant challenge. Proper patient selection is key.
So ongoing monitoring, quality checks, that sort of thing is still really important.
Definitely.
What about looking forward? We've talked about surgery. Are there newer technologies, maybe less invasive options that are changing the picture?
Yes, carotid stenting has emerged as a significant alternative. Using a catheter to place a stent to open the artery rather than open surgery, it's less invasive, which is appealing. But the whole history of CEA serves as a really important reminder here. Any new approach, like stenting, really needs to go through the same kind of rigorous testing, large randomized controlled trials, comparing it directly to the established method, in this case CEA.
So follow the evidence, just like they did to validate CEA in the first place.
Precisely. We need to know for sure if stenting provides comparable or maybe even superior outcomes, and importantly, for which specific patients. It took those landmark trials to prove CEA's worth, and alternatives need to meet that same high bar of evidence before they become standard practice.
Okay, that makes perfect sense. So let's try and bring this all together. For you listening, what's the key takeaway from this deep dive into carotid endarterectomy?
I think the most crucial point is that the NASET study, strongly supported by other trials like the VA study and ECST, provided that really solid, almost irrefutable evidence that CEA significantly cuts the risk of stroke for a specific group. Patients who've recently had symptoms, like a TIA or minor stroke, and have a high-grade narrowing, that's 70–99% blockage, in the related carotid artery. This research wasn't just interesting, it was pivotal. It established the role of surgery in preventing stroke for these people and fundamentally changed medical practice.
Yeah, and it really hammers home the power of rigorous clinical trials, doesn't it? Separating what we think should work or what makes intuitive sense from what's actually been proven to work through careful study.
Exactly.
And it also highlights, I think, the proactive role researchers in this case, including the vascular surgeons themselves, can take in tackling these big medical uncertainties to ultimately improve how we care for patients.
It's a fantastic example of the scientific process in medicine, questioning assumptions, demanding high-quality evidence, and letting that evidence guide practice, even if it means changing long-held beliefs.
So as a final thought for you to consider, thinking about this whole journey of CEA, From that early enthusiasm through the skepticism, and then finally reaching this evidence-based validation. It really makes you wonder, doesn't it? What other established medical procedures, or maybe even common interventions we use today, might actually benefit from a similar kind of deep scrutiny, from ongoing evaluation to make absolutely sure we're optimizing outcomes for patients?
That's a great question to ponder.
It's just a reminder that medical knowledge isn't static. It's dynamic, it's always evolving, and we need to keep questioning and keep testing.